Perfect. Okay. So, make sure everything's on.
Can I just check and see if I'm sharing the PowerPoint?
You are. I can see
Excellent.
it up there. Beautiful.
Thank you.
Okay, everybody, welcome back. So part of what started the whole theme for this today's conference was we got a request for an update on the CARA program. And so I went and looked into it, and I read the report, and I saw that there were some great advances in the use of this program. There's some places where we could do much better in general. So we invited the State Department of Health to go ahead and present today. So we have two presenters, Lisa Merrill. She attended the University of Michigan School of Social Work at Ann Arbor. So you're a long way from home, Susan is. She completed her master's in social work in 1990. Following graduation, she worked as a social worker for the Hemophilia Foundation. She traveled a lot. She moved to New Mexico in 1995, where she was for 5 years with the dialysis social workers in Santa Fe and Las Vegas. She started work for the New Mexico Department of Health and Children's Medical Services as a supervisor for the Santa Fe and Rio Arriba County. And in 2017, she moved over to the state with the CMS when surveillance of birth defects became active due to the Zika virus. So she has led the Department of Health for the CARA program and was instrumental in implementation of the template for the plan of care and training for birthing facilities and MCO care coordinators. And then our other presenter is Lisa. How do you say your last name? Rohleder?
Rohleder.
Okay, Rohleder. Lisa Rohleder. She joined the CARA team in the role of CYFD CARA Navigator in January 2021. Prior to joining CARA, she was the Northwest Regional Coordinator for the New Mexico Family, Infant, and Toddler Program, the FIT program, and previously worked extensively with families and babies birth to 3 years in bilingual English and Spanish development specialists and family services coordinators in Santa Fe. Her career in early childhood development has encompassed teaching and training, program development and evaluation, and direct work with families in New Mexico, Ecuador, Honduras, and the island nations of the Pacific and Indian Ocean. She completed a master's degree at the Institute of Child Development at the University of Minnesota in 1995 and a 3-year NIH research traineeship at the Centers for Cognitive Science, also at the University of Minnesota. So welcome Lisa and Susan today as our speakers, and they're going to give us some good information on the program and how we can work to improve it. So welcome.
Thank you. Thanks. And as you can see, we are state employees, so we have nothing to disclose. No financial. So we also have listed on here other members of our team, Melissa Soto, who is the acting CARA supervisor at CYFD, and Amanda Varaca, who is the other CARA navigator at CYFD. And we're gonna give you a few objectives, and then I'm gonna turn it over to Lisa. But our hope today is that we will help increase your knowledge around the federal and state CARA statutes, how we are approaching CARA in New Mexico as a public health evidence-based approach, the CARA statewide collaborative that is ongoing, and the Plan of Care program, along with our implementation, the look at the SAMHSA continuum of care, which we follow, and our vision for the future for CARA.
Okay, so you may be familiar with the Comprehensive Addiction and Recovery Act as federal legislation. That it's a package of education and prevention policy initiatives and funding that was passed in the last year of the Obama administration. It looks different in every state. One of the one of the changes to policy included an amendment to CAPTA, the Child Abuse Prevention and Treatment Act, and it requires that states identify and report annually on these 3 data points: the number of newborns with substance exposure, the number of those newborns for whom a plan of care was created, and the number of infants with a plan of care who received appropriate services, and referrals were made for those services, not only for the newborn, but also for affected family members and members of that newborn's household. Oops, sorry. And so in New Mexico, this changed our children's code, and also brought our state into compliance with the amendments to CAPTA. And so under the new law that was passed in New Mexico in 2019, CYFD was identified as a lead agency to work in collaboration with the Department of Health, the Human Services Department, New Mexico Medicaid providers to develop rules and guidelines for the care of newborns who exhibit physical, neurological, or behavioral symptoms consistent with prenatal substance exposure, and also including newborns who are known to have experienced newborn substance exposure by disclosure of parent. It included creating a process for plan of care implementation for any newborn with substance exposure. And it required that CYFD and DOH be notified of babies born with substance exposure. And we want to really clarify that notification is made only to the CARA team at CYFD and DOH. And so I want to apologize. I'm having it's taking a little extra effort for me to advance my slides here. I'm sorry about that. Keep going though. So we have a plan of care requirement in New Mexico. Birthing hospitals, birthing facilities are required to offer this plan of care to every family of a newborn when substance exposure has been identified. And when we receive that plan of care, that serves as notification for our federal reporting purposes. And by substance exposure, what's included in that is any substance that can affect a newborn's health and development, including alcohol, marijuana, nicotine, and drugs or medications, whether they're prescribed or not prescribed. So substances such as opioids that we know can affect newborn development. And so, as I mentioned, this has changed our children's code. So the statutes changed in 2019. Prior to 2019, every newborn with identified substance exposure, that family would be reported to CYFD. And those reports were often the basis of a screen and of an investigation and a substantiation of abuse or neglect. So that looks really different since 2019. It's no longer the case that the substance exposure in and of itself needs to be reported to statewide central intake at CYFD. It is still required, of course, though, that any reasonable suspicion that a child is abused or neglected based on other criteria or a combination of criteria that might include substance exposure, those reports are still required to be made. And the CARA program and the CARA team, we never discourage or vice versa encourage the reporting of concerns about abuse or neglect. We know that everyone in New Mexico is a mandated reporter, and everyone's responsible for knowing what that means and making calls to Sky when they have concerns about imminent risk to a child. So I'm going to pause for a second and just see if there's any clarification that anyone would like about that before we move on. And I know we do have a question and answer session coming at the end as well.
I think we're good for now.
As I was saying, it is still possible that a plan of care is being created with the family, but there are concerns about safety for the newborn in the parent's care. And so some of the reasons that we see and that are reasons that hospitals do make referrals to statewide central intake are some of these situations that you see presented. So if either or both parents are not participating in the care of the newborn during the inpatient stay, if a parent is using substances or appears to be under the influence while inpatient or during NICU visits, if there's an observed parent action or inaction that harms the newborn or presents impending harm for the newborn, intimate partner violence that's observed is another reason. And then failure to engage in follow-up treatment for a newborn's medical needs. So this could be happening while at the same time a plan of care is being initiated. And what we know about the plan of care is that when it's well developed and effectively implemented, it can prevent the removal of an infant from family or provide an opportunity for quick reunification if an initial placement is away from the birth mother or father. A strong plan of care benefits an infant and their caregivers by addressing their immediate treatment needs, regardless of immediate child placement decisions. And I believe I'm turning it over to you, Susan.
Thanks, Lisa. So we really look at this from a public health approach and thinking about substance use disorder as a manageable chronic illness or disease. Addiction can be managed. It's treatable. And thinking about the complex interactions among the brain circuits and genetics, people with addiction who use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. We already know that treatment is not a cure, but that's just like anything else. If you think about it with people with COPD, diabetes, or asthma, that there is going to be relapse or a return to drug use after an attempt to stop. But that's part of the process and can be part of the process. And newer treatments are designed to help with this prevention, with relapse prevention. So the relapse rates for drug use are very similar to the rates for other chronic medical illness. And then we think about the return to use and how people need to work with a provider and be connected so that they can make a different plan if that works for them. So when we were looking at this back in 2017, 2018, before we got all this going on, this article came out in November of 2019 and really spoke to punitive policies and practices in different states. Arizona is one of the states in this study. This evidence continues to emerge and continues to support our non-punitive approach and the decisions that were made in policy with changing the Children's Code. I will speak to that as well because there's much more emerging evidence. We know that there's an increase in neonatal abstinence syndrome, or NOWS, as well, when people believe that there's no hope, basically, is how I'm going to say it. It drives them further into their addiction and use, versus seeking that help, which is what we really are trying to focus on. So, are there state child abuse policies and mandated reporting policies for prenatal substance use? So, there is a large study that they've looked at, and this is part of PRAMS, which New Mexico is also part of PRAMS. And this really speaks to that, the fact that state policies that have child abuse only, mandated reporting only, child abuse and mandated reporting, or neither. So we already know that prenatal care is initiated later. There's a lower likelihood of adequate prenatal care and a lower likelihood of postpartum health care. And that's what we are working to reverse in New Mexico. We are still struggling with that. We already know that at the Department of Health, we are looking at that pretty significantly at this point in time. But what's really important is the states with the punitive policies were also states with a higher percentage of births. This speaks to health equity, in my opinion, to Black, non-Hispanic women. And it really suggests and speaks to the policies exacerbating that long-standing racial inequities in maternal health, substance use, child welfare, in access to treatment and care. Many of you may be well aware of the recent release of the Maternal Mortality Review, and that committee is led by Dr. Jillian Burkhart from the university. And it's pretty alarming because it is really preventable when we look at it and think about it. And many of those cases, 47% substance use disorder, 42% mental health conditions, I believe 12% were suicide. So when we think about CARA and our program as a whole, we really have to think about this as well. We have to think about what happens after that baby is delivered, what the treatment and the care is, and how we are helping people access what they need. We're pretty proud about this. Back in December of 21, Tristan Maroney, who was the supervisor of the CARA program, myself and Dr. Andy Shee met with the director of this office of policy, and this just came out, and we were cited as a state example, because we know that pregnant women with SUD are 17% less likely to be accepted for OUD treatment compared to their identical non-pregnant women. And we are seeing this in New Mexico as well. Thank you. Access to treatment is so challenging, and we all know that. So we're working on that as well within the Department of Health, coming up with a better plan in this state for access to treatment. Medications for OUD reduce risk of relapse and death for pregnant postpartum women. We're trying to improve that access as well, as we understand that there may be some shortages within our pharmacies, along with some barriers that require prior authorization. So we're working to reduce all these things. And I think what we want to think about is the infant foster care placements associated with parental substance use and missed opportunities. Okay, Lisa.
Okay. So I'm sure you all are familiar that there are potential short and long-term effects of substance exposure. That exposure to the fetus, as it impacts brain development, can have broad implications for a newborn's health and for newborn and infant health and behavior. Some of the immediate effects are birth anomalies, fetal growth restriction. There's greater likelihood of babies being born small for gestational age. Neural behavioral adaptations, sort of responding differently to sensory experiences, and then the withdrawal that's associated with NAS or NOWs. Potentially the effects of substance exposure in utero can persist throughout an infant or child's life, and or they may appear later in a child's development, while perhaps not being apparent early on. So it just speaks to the importance of getting supportive services in place for the family as early as possible. And in addition to any sort of like physiological impact of exposure, there's also the interaction of mother and baby or caregiver and baby that is equally important in newborn and infant development. And the substance exposure and some of the environmental factors that may be coming along with that can also impact development. And so we see that prenatal drug exposure can occur with other types of ACEs or adverse childhood experiences. And it, again, really speaks to the importance of addressing the needs of infants with substance exposure and complex developmental experiences. And there isn't one agency or program that can really address this complexity. It really involves interventions and systems integration and changes in policy, like we are making in New Mexico. And so this is just an overview of the systems that have come together in New Mexico. And I've been with the CARA team for a year and a half now, so I'm not patting myself on the back when I say this, but to me, this is a remarkable achievement that Susan and other people have made to bring all these systems together to operate in concert with each other to support families and babies. And so CYFD, DOH, ECECD, which was not even a department when CARA was first initiated, but is now like fully involved with CARA. And the Human Services Department, the Medicaid providers are a really key system in the services that are provided under CARA. And again, our partners and stakeholders, you can see as well that families being the first and foremost among those partners and stakeholders. There's a CARA Indigenous work group that involves every tribe in New Mexico. And then all of the community service providers that we partner with, that CARA partners with. And so a newborn plan of care, we're going to focus a little bit on what that looks like and the process by which those are created. It is considered a 2-generation care model, and really it can be 3 and 4 generations, as services that are extended under a plan of care can involve everyone in a baby's household, including grandparents and great-grandparents sometimes. There's an array of services. So we know that babies thrive when their parents thrive, and families need, sometimes they need basic supports of financial assistance or transportation or food. There are substance use treatment and recovery services available, and mental health services that can be accessed through a plan of care. And then care coordination. Most of the babies who have a plan of care, and most babies in New Mexico, the majority have Medicaid. And so Medicaid care coordinators are really important people who assist families in the implementation of their plan of care. And the plan of care is really, it belongs to the family. So it's created at the hospital with a healthcare provider and the newborn's caregiver, and it's created in partnership. The process encourages discussion about family resources and strengths, as well as family needs, and really tries to identify those priorities that families have for themselves. And it is voluntary. So a family can choose which services they'd like to engage in. They can also decline a plan of care completely if that's what they would like to do. And the plan of care is typically created with the newborn's parents, but in cases where there is simultaneously custody that's being decided, if a baby is in the care of someone else, that plan of care it can be created with those caregivers. So this is what the paper template of a plan of care looks like. It covers some basic information, some basic demographic information. It's really created so that there's information there so that the care coordinator, well, first and foremost, the family, but then also a person who's going to support that family and walk alongside them in the implementation of this plan so that they have the basic information recorded in this document to help them do that. So the infant's PCP, who the household members are for that infant, and their key contacts, because we know that sometimes the people who are most important in a parent's life aren't the people who live in their household, but they're still really key people in that baby and that parent's life. The substance exposure, and then services that may be offered to the family are recorded. And there is an acknowledgement of understanding and release of information so that basic information on this plan of care is shared with the CARA team. And that essentially is like 6 people at this point, or when we're fully staffed, 6 people, as well as the care coordinator, the PCP. And so here's just another sort of overview of what that process looks like from start to finish when a baby is born. And you can see also on the left that it's always been a vision that that we sort of intervene earlier in families' lives to support parents during that prenatal period as well. The focus for CARA, though, since 2019 has been on the newborn plans of care. And so you can see, like at the time of the hospital, when they've identified that a baby has substance exposure, there's also the question about if this baby or parent has tribal membership or affiliation, because we encourage hospitals to bring in family supportive services from a family's tribe or pueblo or nation, so they are as well actively involved in the creation of a plan of care and offering services that may be specific for that tribe to the family. When we receive a plan, we are looking into whether there has been a SCI referral in addition to that plan of care. And if there has been, then we coordinate with the CYFD field office workers who are going to be involved with that family. And we really want to link up those people as well with who the care coordinator is going to be for that family, who's going to be helping that family with the implementation of their plan. So it's really, there's a lot of communication that and collaboration that happens to support these families. And We know that families are touched by a lot of different systems, and a really big goal of CARA is to have those systems be in alignment for the benefit of the family. The plan of care is in place for minimally the first 12 months of the baby's life. And there's a reassessment at 1 year of age to see about the continuation of the plan. We know that families' needs change also. They can change drastically in the first year of a baby's life. So there's always the potential for that plan to shift and change to meet those needs. And CARA navigators we are the folks who also are facilitating that collaboration. When something seems to be breaking down in the communication with families, our role is to help re-engage families. Oops, sorry about that.
It's bouncy. Oh, so this page is just a snapshot of some of our services and the outcomes for 2020 to 2021. I have to tell you, when Nick Sharp, who's our data evaluator, did this, we were at 2,300 plans of care. We're now at over 3,000 plans of care. But what it does tell us is in that lighter orange, it means that on the plan of care, it was reported to us that that service was current. Then the middle brown is declined, and then that green is referred. And then there's a really darker one. I'm just taking a look at this. It's kind of interesting. That says maybe unavailable, but we know that most services are available in the community. So, and there's been a big expansion since the rollout of these services. So that's really what this means. And one of the biggest services that our families are engaged in is WIC. I would say WIC, SNAP, any of those benefits, we find that most of our families do engage. And one of the other, when we think about strong plans of care, we think about home visiting referrals and early intervention referrals as well to support that newborn and that development for families, along with then, of course, treatment services and any other supportive services families need. This is the continuum of care that we were talking about earlier. So really, we're thinking about pre-pregnancy, and this is the area we are moving upstream in New Mexico. We have a lot of work that we are doing and looking at this and how we can move into the implementation of prenatal plans of care. So it's taking us a little time, but we are very much working on this. But we really believe that this is a time when interventions can include promoting awareness and education and access to care, really, in essence. And also, healthcare providers have a great opportunity to be talking with somebody who's expecting and thinking about this. This is where universal screening comes in asking the questions with a validated tool that really speaks to and can identify substance use or mental health needs as well. Then, of course, at birth, which is when the plan of care is developed, and that's that's another point of intervention. And then after the baby, after they go home, and healthcare providers can continue to conduct their developmental assessments, reviewing a plan of care with families, ensuring access. And we do have a fair number of primary care providers who now are able to receive plans of care. We have to increase that. I will state that over and over. We need to increase that because those providers who are working with a family with a plan of care have reported back that they really do like it and are very supportive of it. And then, of course, continuing on, right? That child and that family will continue to always be needing or ask the questions, what do you need and what services? So the best practice and the vision for the future, we are well aware. Abby Reese is our maternal child health program manager here at the Department of Health. She's a certified midwife, I apologize. And I know she worked at the university. She's wonderful. And we are very mindful of the access to prenatal care. We have what are called perinatal deserts in New Mexico. Universal screening, which I did touch on at that first visit for substance use, ACEs, domestic violence, and other needs or risk factors with a validated tool. I can't speak to that more strongly than I am today, but I'm really, really advocating and have always advocated for this. Expand or replicate wraparound services programs for families that integrate SUD treatments where they can with prenatal and early intervention, and not just SUD treatment, but also mental health services. We see that done very, very well in our federally qualified health centers where they are able to find providers to do that. It's not every center. That's the other shortage, as you all know. And of course, at the university, at the Focus program, we have, other programs out there as well. We have the Loveless Grace program. If we can integrate all those into one place, that makes it much easier for people to access services and care. And I see a question in the chat, and I think we have just a couple minutes, and I will answer that question for you. So one of our big focuses is also on harm reduction strategies and having a conversation with our families and with our parents who are in treatment or are going into treatment and making a plan with them and giving them the tools that they need, which include Narcan education and training for everybody. And there's a great phone number on here. It's called Don't Use When Alone. It's a 1-800 number. So this is one of the big things that we are focusing on and specific to our pregnant population. In pregnancy, we think about education on the potential effects of substances during pregnancy on the expecting parent and the fetus. And this is where the maternal mortality, this is where the prevention work is, where we can help save lives. That's basically how I see this. Consistent communication through systems including public health campaigns, industry messaging, access to reproductive health care. So again, it's pushing out that need for early and ongoing prenatal care, including vaccinations, the universal screening, reducing adversity and stress. We can't speak enough to the racial inequities and the stigma that are involved with this, and supports for safe use and decreased use, and increasing our medication for opioid use disorder. And then, of course, there's the postpartum care. And we're getting to the end, so I apologize, but this is a real big part of our education too. So again, best judge practices around non-judgmental and collaborative care, supporting people where they're at with harm reduction, and providing those interventions that prevent stigmatization, discrimination, criminalization. We've done I'll just say it briefly, family qualitative surveys and follow-up phone calls. And we've heard a lot from our families and from our folks who've delivered. We've heard a lot about stigma and bias and what stops people from seeking postpartum care. They're fine with getting the care they need for the newborn. They struggle with getting the care for themselves. Stop the stigma. Oh, that's a great question, Patrick, because I did all the follow-up here at DOH with pregnancy and COVID. So absolutely, we saw that as a challenge. Anyone can become dependent on drugs and struggle with addiction. Opioid use disorder is not a moral failing. And we need to remember we can all change this conversation and decrease the stigma around drug use and addiction. And we must reduce it to encourage people to ask for help in recovery. And then we'll speak really briefly to this because the other big campaign that we're rolling out is around SUID, sudden unexplained infant death. And so one of the conversations we always have with families is, do you have a safe space for the baby to sleep? Do you have a crib? Do you have a bassinet? And do you need help in receiving those if you don't have that available to you? And we have great tools and ways to get people what they need. ECCD's become a big partner, and they have a wonderful resource and referral line. I mean, we have lots of resources and ways to help people access. Congenital syphilis, I know you're all well aware of this. We're number one in the country. That is because we believe strongly at the department that people are afraid to seek care. They're getting late, and they often show up in time for delivery, right? And so not only are you having to treat the baby, you're also having to treat the person who delivered. So this is a really important campaign as well, and part of what makes us really want to work harder to help people understand that it's safe and it's okay to ask for help and to get the care they need. And here's some more resources. And this is our webpage. And this is our brochure with all of our contacts. So please feel free to reach out to us at any point in time. I'm going to go ahead. There's a question in the chat, and first question about early intervention. Are you going to do you want us to answer that?
Yeah, there's
okay.
a few of them. Is early intervention and home visiting an automatic referral if families have a CARA plan?
Right. So currently it's not. It's not automatic. And that's a great question. A lot of time people ask if it's mandatory, and it's not mandatory, but we would love if hospitals would make it an automatic referral. I mean, that it would be offered, right? That it would be. Mm-hmm.
Yeah. How did COVID affect the work and seeking care? Did that put us back? It feels like it put us back in so many things.
Yeah, the access to care issue, you're absolutely right. And a lot of women, a lot of people that delivered reported, one, isolation, right? Because all of the policies we had to put in place with moms and babies and not having that support person there to help them with that delivery. I spent a lot of time on the phone with people who were pregnant with COVID. I just can't even begin to describe the anxiety that I would follow pregnant people for a couple of weeks until they felt well enough and were connected. There was a lot of telemedicine. Providers were fabulous at reaching out and connecting with their patients, but yeah. So
when there's a care program developed, is it shared with the parents' providers also, or is it just with the baby's provider?
At this time, just the baby, because the plan of care is only on the newborn. That's a great question.
Yeah,
Dr. Sinnott.
I'd make it bigger. And
well, just to clarify that a little bit further too, we don't share a copy of the plan of care with providers other than the primary care physician and the MCO, just because of the confidential nature of information that's documented on that plan. So a provider who receives a referral, they understand that the family has a CARA plan of care, but they won't know the details of some of the information that's documented on that plan.
Right. I'm thinking, though, the question is also, Lisa and Lou, if we did a prenatal plan of care. So that as we move upstream, if we have somebody who's expecting and we do a plan of care with them, and they tell us who the provider is and give us permission, we would then share it. I mean, it would be just like the newborn's plan of care.
Yeah.
Mhm.
Yeah.
Somebody asked, how long are cases followed? I think you said initially 12 months.
Yes, 12 months. And then there's a reassessment with the family at that point. There's always a chance throughout those first 12 months that the plan might change and shift. And I was going to mention that in terms of COVID. That was a big factor for plans needing to be updated or changed because families' needs were really changing kind of all over the place. And housing was one of the biggest issues that we were seeing, and really a lack of resources for housing. But it can continue beyond those first 12 months.
Myrna has a really good question. She says she wonders if it could, what it would take to change the standard of care so that the presence of a CARA plan would mandate an automatic referral to a home visiting program. Is that something you can follow up on your end? Is there a collaborative process with the hospital and birthing centers in place? So that's a lot of questions there.
Yeah, unfortunately, we are considered a non-mandatory state. So we have, and this has been asked a lot, and I can tell you, working with ECCD where home visiting sits, that's probably not ever going to be a policy or something that we'll be able to change at the state level. What I mean about automatic referral is that if a provider says, because at this point it's being offered, what I believe is that it should be automatically offered to every family. I don't believe that it is being universally offered, just like we're not doing universal screening.
Right. So, and I noticed, I read the CARA report, and I noticed that there are places that some parts of the state that who aren't following through with the program as well. So what kind of training should we put in place in those areas to go ahead and help get everybody up to speed in those facilities?
Sure. So in fairness, we really have trained all the facilities. We circle back and talk with them sometimes multiple times during the year, depending on, but the big challenge is staff changes, right? So not every facility or hospital has a case management or discharge planning department, for example. Mm-hmm. Many facilities do not have medical social workers, so we have some places where it's the labor and delivery nurse who's talking with a family about a plan of care. So we have to be really mindful of that and respectful. Does that make sense? Mm-hmm. So what we do is, so we work pretty closely with those facilities to say, how can we support you? What can we help with? How do we, because we do know and offer that, but because it's true. That is where we see our gaps. The other challenge is we have some facilities that have literally stopped birthing babies.
Yeah. Yes. There's a lot of those actually.
Right.
It's not the
and then a year ago on the eastern side of the state, we had an OB practice shut down. So I was talking to people that were going to go to Texas to get their care. And I was like, oh.
Yeah.
Right. So that's where we think about it. But that is, you're right on with. So we've worked really closely, and we continue to develop and make sure that we stay on top of that. And even with the turnover of staff, if that makes good sense. I don't know, Lisa, do you want to add something to that?
No, I don't, Susan.
Okay.
Yeah, the turnover in staff, when I'm out in the state teaching, a lot of the places I visit, they have over 50% of their L&D staff will be travelers at this point in time, which is a huge difference from 2 years ago when that wasn't happening at all. There was a question that was actually asked for a prior speaker, but I think it's probably a better question for you guys. Medicaid and Medicare doesn't allow other passengers when they do transportation for families, I guess. And so the question is, do you feel like maybe that impedes families from actually seeking some of this care because they don't want to go by themselves? They don't want to just pack up the baby by themselves and get into a car. And would it be better if we could change that to where they could take a support person with them on the ride? And how could we change that? Who do we talk to? Who should we call?
Yeah, that's a really great question. Seems to be a Medicaid rule. it's within it. I know that the Medicaid plans and even the fee-for-service, they all contract with different transportation providers. So we could probably ask that question maybe of HSD, because I totally agree with that question. Because I'm thinking it's in a contract somewhere, but I have no idea.
Yeah,
it comes up a lot though.
Yeah. It's really, really weird. And you guys will be sending out your resources, which will be really, really great for everybody. I think that this is really important. And it goes really nicely into, the whole making sure that we're doing really good mental health for our families and for our moms, right, and really doing trauma-informed care. I think that really flows very nicely into the whole CARA program. We probably will continue to get updates on this for the next couple of years. We'll ask you guys back to talk about it again, just to see what we can do. Let me see. Everyone asked HSC everybody asked HSC to change the transportation rule. I think that's a great idea. I'm a very big supporter. Like, you can do a lot in the state if you just start calling people. It's amazing. So we're still small enough that works out really, really well.
Absolutely true. Absolutely true. And I will say that our partners at HSD and the team there are really great and, are at the table. So I think we can take this back and say, what do we need to do?
Yeah.
How do we? Yeah.
All right, guys, we're going to take a short break while we wait for our other speaker to come. She's in Chicago, so she's probably eating lunch or something. I don't know what the time is out there. So why don't you guys take a short break? If anybody has any other questions for Susan or Lisa, why don't we can get them out of the way now. It was a great presentation. Thank you so much for joining us today. I really appreciate it.
Thanks for having us.
Yeah, thank you.
Okay.